Good afternoon, everyone, and welcome to the Health Plan Strategies for Managing Asthma, Key Findings from AHIP's Asthma Assessment. This is a webinar hosted by America's Health Insurance Plans in conjunction with the U.S. Environmental Protection Agency. Next slide, please. I would like to thank everyone for joining us today. My name is Chris Riegel, and I'm a Senior Health Research Associate for AHIP, and I will be moderating today's discussion. Next slide, please. Before we begin, a few housekeeping notes. We ask that all attendees please place your phone lines on mute. For this webinar, we will be using the chat feature in the webinar for questions. Questions will be addressed at the end of the webinar and at the end of the presentations. Slides will be posted after the webinar at ahip.org/asthma, where you can find other asthma-related resources and past webinars. Next slide, please. Today's webinar is about the AHIP Asthma Assessment. This assessment and discussion are parts of the 3-year initiative that AHIP has with the EPA. Goals of the cooperative agreement are to identify and promote health plan best practices in asthma care, accelerate efforts to assess and disseminate health plan interventions, and complement the EPA's indoor environments program priorities and goals. Next slide, please. Our first speaker today is Tracy Mitchell of the EPA's Indoor Environments Division, and she will tell us about the work that they are doing on asthma management.
Hi, everyone. Thank you, Chris, and thank you to AHIP for the important work they're doing to promote asthma interventions with health plans across the country. My name is Tracy Mitchell, and I work for the U.S. Environmental Protection Agency in Washington, D.C., and I'm the project officer for the cooperative agreement with America's Health Insurance Plans. Today, I'd like to just talk about one component of EPA's asthma program, and that is supporting communities to deliver sustainable in-home environmental asthma interventions. Next slide, please. So I'd just like to ground everyone in the public health problem that is asthma. As we know, asthma is an important public health challenge that affects millions of Americans. Our colleagues at CDC tell us that asthma affects over 6 million children, and that's approximately 1 in 12 children in the United States. Asthma carries a significant personal and economic cost, and the prevalence of asthma is particularly high in minority populations, specifically African Americans and Puerto Rican populations. It's also very high in children living in poverty. And so we know that these are disproportionately impacted populations, and oftentimes these populations have asthma that is out of control. Next slide, please. So why are we invested? Well, as I said, out-of-control asthma drives up healthcare costs, and each year asthma costs over $50 billion in direct and indirect medical costs. Some of these costs, like medications, are unavoidable. We know that that's important. Medication is important to control asthma, but we also know that a portion of these costs attributed to out-of-control asthma are avoidable. Healthcare utilization, such as hospital stays and emergency room department visits, drive up costs, and it doesn't have to be that way. Children with asthma frequently end up in emergency room departments and hospitals, and oftentimes it's because they and their caregivers aren't able to properly manage the diagnosis of asthma. CDC estimates that 40% of children and almost half, or 50% of adults, suffer from uncontrollable asthma. So again, uncontrolled asthma leads to increased healthcare utilization, and that leads to high rates of costs in medical and in direct and indirect costs. Next slide, please. So what's EPA's role in asthma? So I think the science is very clear that the environment plays a critical role in asthma. The science says that managing and treating asthma requires multiple components, and one of which is critical is the environment. Asthma control depends on access to in-home interventions, especially in those disproportionately impacted communities that we talked about. So scientific and healthcare experts, most notably our colleagues at CDC and NIH, recognize that the environment is a critical component in comprehensive care. Allergens and irritants found within the built environment can exacerbate asthma symptoms and make asthma harder to manage. We know that common asthma triggers include mold, dust, pests, such as cockroaches and rats, animal dander, and tobacco smoke. We also know that reducing exposure to these triggers by maintaining a healthy home has been shown to improve health outcomes. The way to reduce asthma triggers in the home is through environmental interventions. Effective in-home interventions are home-based, multi-component, and multi-trigger. Home-based interventions often include home visits by a trained individual who can help identify asthma triggers present in the patient's environment. The home visitor then educates the patient and through their support network finds ways to reduce exposures to these triggers by modifying the home environment and changing behavior. A successful asthma program is a local solution that relies on the community developing a program that's best for their specific population. These programs provide a good value in, again, preventing medical costs and missed school days and work days for families, and again, saving dollars. Next slide, please. So again, EPA's role, we are seen as conveners, we're seen as experts in the built environment in homes and schools. We have the tools to address the health risks and to develop services at the intersection of the built environment. We know that good health starts at home and that people look to us for guidance on how to effectively manage their environments and improve health outcomes. Community systems are critical to supporting and developing the delivery of care outside the clinical setting, and EPA, again, knows how to convene these stakeholders, synthesize the learning, and translate the learning into practical, usable information. We also recognize the potential to meet people where they are. So this, again, is our unique contribution. And so several years ago, we launched AsthmaCommunityNetwork.org, which is a platform that provides engagement to over 1,000 community programs to share, learn, and connect on the most effective programs on addressing asthma. Federal partners, our colleagues at CDC and HUD, through the Asthma Disparities Action Plan, are collaborating to coordinate efforts and leverage resources and support community efforts across the country. Next slide, please. So in this diagram, you'll see, again, how through partnerships we support high-value in-home environmental interventions. The graphic represents EPA's major program areas that support our work to enable communities to deliver and sustain in-home interventions as part of high-value care. The idea of this puzzle, the house on the left, is that the puzzle pieces are interconnected and rely on each other to complete a picture that symbolizes how EPA's major areas of work fit together. Central to all of these are EPA's role as, again, technical experts in the built environment. We meet communities where they are, most effectively supporting high-value in-home environmental interventions. We recognize best practices through our National Environmental Leadership Award in asthma management. Hopefully many of you were able to sit in on last week's webinar where we featured those winning programs across the country. We provide learning space and facilitate a national network of these local programs, again, through Asthma Community Network. We offer technical assistance for communities and health payers. We pace action locally through summits and other events and coordinate our federal partners, again, through the Asthma Disparities Action Plan. So to the right, you see that we believe that the key function of our office is to synthesize the spread of learning related to increased cost savings and expanding the workforce that will ultimately lead to decreased healthcare costs. Next slide, please. So just to quickly talk about our goals and how we're achieving those goals. By 2018, EPA has a goal of assisting over 1,000 communities nationwide to deliver and sustain high-value in-home environmental interventions that reduce urgent care utilization costs and improve asthma control across the country. Again, I mentioned Asthma Community Network, so that is a platform for engaging community programs to share results. I mentioned the National Environmental Leadership Award in Asthma Management. Over the last 10+ years, we've awarded 41 programs across the country, and you can learn more about these award-winning programs on Asthma Community Network. We offer technical assistance, again, through Asthma Community Network, but by working with partners such as AHIP and the National Center for Healthy Housing. We've been co-hosting asthma summits across the country with our colleagues at HUD and CDC. We've had 11 summits over the past several years, impacting 16 states and reaching 700 participants. And again, these are healthcare providers, health plan representatives, and federal agencies and state agencies across the country. And we're bringing it all together, again, by equipping programs and by spreading best practices through vehicles such as this webinar today. Next slide. So I'd like to just close by, again, kind of understanding how this work fits into what you're going to hear about today. And we realize that this slide kind of represents the importance of bringing multiple funding streams together, the concept of braided funding to cover the full spectrum of in-home asthma services, as we talked about. And so you see in the middle there's education, educating patients about their triggers, specific triggers in the environment, about assessment that is looking at the home to figure out which triggers are important to that specific patient, and then the interventions, and that is providing supplies as well as instructing people on the best practices for reducing their triggers in the home. All of these services require funding, and so this is really the intersection between healthcare funding, which includes things like Medicaid and private insurance programs, state and local health departments, and the intersection with housing funding, which relies on healthy homes projects, which oftentimes address structural or housing issues. So with that, I'd just like to thank you for being here today to learn about this important work and to learn about the efforts of AHIP on health, and learning about health plan strategies and their roles for managing asthma across the country. With that, I'll turn it back to Chris.
Great. Thank you very much, Tracy, for your presentation. Next slide, please. Our next speaker is Shirzad Abduqadirov. Shirzad joined AHIP in January 2017 and has a PhD in public policy from George Mason University. He has 15 years experience in social research and policy analysis, and Shirzad has been leading the AHIP analysis of the assessment findings, and he's here today to walk us through those findings. So with that, I'll turn it over to Shirzad.
Well, thank you, Chris, and thank you all for joining today. Can we go to the next slide, please? Okay, so as part of our collaboration with the EPA, we have conducted 2 surveys in order to get essentially a snapshot of where industry is with regards to home-based assessments and environmental asthma management programs. So the first survey we conducted early in 2015, and then the follow-up survey we conducted in late 2016. So these surveys were about 1.5 years apart. And because we knew from the beginning that there would be important differences between commercial and Medicaid plans with regards to asthma programs, we have decided to split our surveys into 2 categories, and we essentially assigned plans to either commercial or Medicaid buckets. And in order to do that, we first looked at the enrollment, share of enrollment in either commercial or Medicaid plans, and the plans that had, say, 90% of their enrollment within Medicaid market would be assigned automatically to Medicaid category. Those who had 90% or above in commercial market would be assigned to commercial category. And the plans who had more evenly balanced enrollment in both markets would essentially be randomly assigned to one or the other category. But we specifically asked the plans when we fielded the survey to answer the survey specifically with regards to that particular market, either Medicaid or commercial. And in 2015, we got 60 responses, 60 plans responding to our survey, and they were roughly evenly split between commercial and Medicaid. And they were, in terms of enrollment, they represented almost 94 million covered lives. In 2016, we had 42 plans, again, relatively evenly split between commercial and Medicaid, which kind of gave us a good ability to compare both programs. And they accounted for almost 77 million covered lives. Next slide, please. Can we go to next slide? Okay, thank you. So because there's only so much you can learn from surveys, we've decided that we needed to complement these survey findings with more in-depth interviews in order to dig deeper into certain issues and get the more nuanced picture or I guess explanation for certain findings that have puzzled us from the surveys. So we have conducted a total of 9 follow-up interviews. 6 of them were after the year 1 survey, and 3 additional ones after year 3 survey. And in order to get a broad picture of a broad range of perspectives in both years, what we try to do is to make sure that we include both commercial and Medicaid plans. And the first year, we included the plans that had home-based assessments and those that did not. In year 3, we specifically reached out to plans who have either started or have stopped offering home-based assessments since the first year survey. In addition to surveys, well, let me mention also that for each of these interviews, we have conducted them in a structured interview format, which means that we have drafted the questions up front and made them available to the plans before the interview so that these responses in our interviews would be comparable from one to another. In addition to interviews, we have conducted 2 roundtable meetings here at AHIP offices. And these roundtables included a total of 25 plan representatives. And again, as with interviews, we made sure that we have a broad range of perspectives in the room. So we've invited plans who did not have home-based assessments and the ones who had very successful, well-established asthma programs, and specifically home-based assessment programs, so that we would hear different concerns and different perspectives from our plans. Next slide, please. So the findings that I will present today essentially draw on all these sources of information: the surveys, the interviews, and the roundtable conversations. And when we compiled and analyzed our data, what we found was essentially there were 5 major themes that emerged out of these findings. The first key finding had to do with racial and income-based disparities in asthma outcomes, and specifically the measures that health plans were taking in order to address these disparities. The second major theme was the role of partnerships in environmental asthma management. The third major theme was the challenges that health plans were facing with engaging their members with asthma. The fourth major theme was the challenges they were facing was figuring out how to fund their home-based assessment programs. And finally, and I guess this was, at least for me, the most interesting finding theme, that we found that there was a certain balancing act that health plans had to engage in between trying to make sure that their programs were effective and at the same time trying to make sure that they could ensure the long-term financial sustainability of their program. So let's consider these findings in more detail. Can we go to the next slide, please? So one of the questions that was very important specifically for EPA from the very beginning was to see what measures are health plans taking in terms of trying to reduce racial and income-based disparities. As you saw from Tracy's slides, this is a major issue and it's a major concern for the EPA as well as AHIP. And the initial findings from surveys were not very encouraging. In the year one survey, we have asked our health plans if they collected data on race and ethnicity, and 2/3 of plans responded that they did not. And this obviously presents a barrier, because if you don't have even the data on racial composition of your membership, it would be difficult to structure programs that would address the disparities. Can we go to next slide? So another finding that, again, was somewhat discouraging is when we asked our members what factors do they use in deciding who to target with these home-based assessments, or who would be eligible for home-based assessments. Almost universally, plans responded that they were driven primarily by high frequency of healthcare utilizations, and specifically ER visits, and poor medication adherence. And as you can see at the very bottom, you have the factors relating that very few plans actually use race, ethnicity, or English as a second language, with essentially factors that would speak to cultural diverse populations or socioeconomic status. And I apologize for a very busy slide, but I wanted to show you that we've actually gave our plans a wide range of options, and the factors relating to income or race and ethnicity came in dead last out of all the factors, possible choices. So that was sort of discouraging to see, but then we started digging a little deeper, and what we found was actually the picture was not as bad as it seemed originally. Can we go to next slide? So one thing that we found early on was that Medicaid plans seem to be much more effective and much more likely to offer home-based education, assessment, and remediation. As you can see, more than half of them, actually, more than half of Medicaid plans responded that they offered these services to their members. And since Medicaid plans serve primarily low-income populations, that essentially means that the higher prevalence of home-based assessment programs among Medicaid plans means that these plans are much more available to low-income populations. Next slide. Another thing that we found is that even though health plans were not offering, they did not use income or socioeconomic status as an eligibility criteria or in order to target their home-based assessments, they did offer certain measures that would increase their members' access to these services. So, and especially Medicaid plans were more active at this. So things like offering transportation to healthcare appointments, or offering home assessments at hours preferred by the member. These would be the types of services that measures that would essentially increase access for low-income populations. Next slide. Similarly, you see that health plans, again, mostly Medicaid, but even commercial plans, were establishing measures that would essentially increase access and make it easier for their racially diverse populations to get access to their services. So they would, health plans would tailor their asthma materials to be culturally appropriate. They would hire community health workers and case managers from similar cultural linguistic backgrounds, and they would also provide asthma materials and their websites in multiple languages. So what this essentially points to is that even though health plans did not have explicit programs or measures to target disparities, racial and income-based disparities within asthma programs, they did actually address those disparities in two ways. First, by making their services available, so by establishing measures that would increase access for their culturally diverse and low-income populations for all services. They covered asthma programs as well. It's just these programs were not specific to asthma. And the second measure was that what we found, and this essentially came more through the interviews, is that the health plans that were more likely to offer home-based assessment programs were the ones who served populations which had a disproportionately high ratio of asthma, and specifically uncontrolled asthma. So by focusing on these on populations that had asthma, high prevalence of asthma, they sort of in a roundabout a way were actually making the home-based assessments more available to these populations. Next slide. So the next major issue that was of importance and that was one of the major findings was that partnerships were crucial to making to successful environmental asthma management. As you can see from the slide, many plans already reported that they already partner with different stakeholders, and what you see here are the ones that are most frequently cited as important partners. And you can see that members and hospitals were frequently named as important partners, but also local health departments and community-based asthma coalitions and health centers. Next slide. What was actually striking is that when we asked our plans to if they plan to partner in the future, you saw almost a nearly universal expectation to partner with major stakeholders on asthma. So next slide, please. And this essentially, it especially came through when we were asking about the importance of partnerships when we actually asked the plans who had home-based assessments. And what we saw is that more than half actually reported developing their home-based assessment program with another organization, with a partner organization. Even more plans reported partnering for implementation, so essentially running and actually doing the assessment usually was contracted out to a partner. But this, however, there was a certain nuance when we started actually going into follow-up interviews. So even within follow-up interviews, what we found is that most plans thought that partnerships were important. However, we found two nuances. The first one was that one plan that started out by contracting with visiting nurses organization for running their assessment decided to actually bring that program in-house, and they started training their staff to be community health workers so that could actually rely on their internal staff to run, to actually do home assessments. And the reason they gave us for this change was that they felt that by contracting out the implementation of their home assessment program, they were losing some of the important information and lessons that normally come, that you can learn by actually running the assessments in-house. And the second piece was that they felt that contracting out their asthma program was impeding communication internally about this program. So by having this, the asthma assessors internally, they hope that that would improve the communication within the organization, that would allow them to serve their members' needs better and understand their members' needs better with regards to home assessments. The second nuance was actually coming from several plans that did not have home-based assessments. And for them, what was essentially, when they were saying that partnerships were important, what they really meant was that they were not entirely convinced that it was really, that they should be, that it is their role to actually lead this effort. Essentially, what they were hoping is that someone else would be leading the home-based assessments efforts and asthma assessment efforts within their community, and they, as plans, would essentially serve in a supporting role and certainly participate in the effort, but would not actually lead that effort. Interestingly, in a roundtable, when we heard from two plans with well-established and successful programs, they too pointed to importance of partnerships and the fact that it was their partners who were running the assessments, but they stressed the importance of finding the right partners that can actually be successful in implementing these programs, and I will touch upon that in our next section. So that was the key finding from our roundtable. Next slide, please. So another major theme that came through both in surveys, but particularly in the interviews, was the challenges that members were facing that health plans were facing engaging their members with asthma. And these were Medicaid plans were especially vocal with these in this section. So health plans indicated that seeing more engagement from their members with asthma was critical to the success of their program. And they were noting that a large portion of their membership actually had problems with asthma and with medication adherence. And yet, despite all that, they found that a significant portion of their membership saw asthma as a low priority activities, given all their other social and economic burdens. And beyond seeing it as a low priority, what health plans, a frequent problem that health plans ran into is that a significant portion of their members would not even allow health workers to come in and do the assessment, and frequently they would reschedule their appointments. Next slide, please. So in the follow-up interviews, we heard from the plans that this was actually a major issue, lack of cooperation. And interestingly, what we heard is that in many cases, the health plans were, I'm sorry, I'm getting some technical issues here. What we heard is that health plans very often what they were facing is that suspicion from their members. Essentially, a lot of their members would treat all figures of authority with suspicion, and they would not necessarily see a difference between the nurses or health workers coming to do the assessment and the local police or local government agencies. And they would frequently, and some of the plans told us that essentially some of their members were afraid that they were child protection services, or that they would report, that they were afraid that the health workers would report them to the local authorities. So because of that, they very often they would essentially not let health workers inside to do the assessment. Another major problem that especially Medicaid plans were facing is that a lot of their membership was very hard to reach. They were transient populations. They did not have good phone numbers on record, or they would not have good, or sometimes they would not have even phone numbers at all. The other problem, especially for rural areas, was the sheer geographic spread of their population, so that the members that they needed to go to the homes would be miles and miles apart, so it would take a long time for assessors to reach their members. And especially with children, the frequent problem was that some children were living in multiple homes, so they would shuttle between, say, their parents' and grandparents' homes. So even if you address environmental triggers in one of the homes, children were still facing environmental triggers in the other home. The other thing that came through when we asked health plans about the lessons learned and what steps they could take in order to improve member engagement and to improve the numbers of houses that they can go into. The biggest lesson learned for the plans who have not been able to actually get into homes was that you need to start thinking from the perspective of the members. So one of the plans that actually had a program and discontinued it because of the lack of engagement told us that when they approached their program, they thought it was self-evident that this program is beneficial to members, and yet most members did not see it that way. So you really had to, they stressed that you really have to think about it from their perspective, because asthma for most members is such a low priority given all the other issues they're facing. Another plan that was actually quite successful in reaching a lot of homes and reaching a lot of members, they reported that they specifically thought about it from their members' perspective, so they did not necessarily limit their activities to assessment. They stressed that assessment itself was not enough, that you also need to offer remediation services. And there were two reasons for it. One, it allows plans to be proactive and essentially go and take care of all the environmental triggers instead of relaying all these information to the members and expect them and wait for them to actually do something about it. The second part, however, was actually speaking to the low engagement and thinking about it from the members' perspective. When plans offer remediation, they would often come essentially with a bucket of goodies that they could give to their members, like air filters or some cleaning soap or some vacuum cleaners and so on. So this would essentially entice some of their members to actually let people in and let the health workers in and to conduct the assessment and remediation. And final issue, the final point was that there was a need to establish trust, and that was one of the reasons the plan that I mentioned earlier brought their program that they contracted out previously in-house, that they found that they were able this way to capitalize on the relationship they already have established with their members over telephonic assessments and through previous calls by case manager, so they can actually ask for the member to allow them into their home and have that member actually the same member who talked to the same case manager who talked to the member over the phone come to conduct the home assessment. Next slide, please. So the other challenge that most members were facing was figuring out how to fund these programs. And well, on the positive side, most plans thought that home-based assessments have a potential to reduce costs and reduce the unnecessary healthcare utilization. So essentially, most plans thought that these programs have the potential to essentially pay for themselves. Unfortunately, very few plans said that they have seen financial return on investment from providing home-based assessments. Now, let me point out here is that part of it could be because, due to the fact that conducting ROIs is very difficult, especially given the transient population. So that may be simply the difficulty of actually getting the ROI numbers rather than not having a positive impact. Next slide, please. So, and yet universally, plans were saying that they were still concerned about having sufficient administrative funds or external funding or community benefit funds. And they all saw high cost of conducting home-based assessment as a barrier to them being able to offer these services to their members. But the costs to plans actually go beyond the dollars. It also, these home-based assessment also impose substantial costs and substantial demands on the time of the health plan staff. So that leads me to the final point. Next slide, please. That what we found is that there was a certain trade-off between program effectiveness and its financial sustainability. So essentially, there were broadly speaking, there were two options for health plans that we've seen being utilized. First was to partner with an external provider, like visiting nurses. And the benefit of this approach is that, especially if we're talking about providers who are essentially medical providers, you can charge this as a medical expense and essentially process it as any other covered medical expense. So on some level, this is the most financially sustainable, long-term sustainable route. The downside of this approach is that it costs plans on the engagement side, because in order to be able to charge it as a medical expense, these have to be conducted by somebody who is a medical professional, and they have to essentially include a medical component, mostly educational component during the assessment, which essentially precludes health plans and does not allow them to the flexibility to, let's say, include health workers, community health workers, or provide a remediation services which would not be, which you could not treat as medical expense. And given that asthma is such a low priority for many members, that really costs health plans in terms of their engagement. Next slide. The other alternative is to actually develop the program in-house and essentially fund it through either administrative funds or external funding, which would allow plans the flexibility to structure it in a way that would improve the member engagement in these programs. So you could train and hire community health workers. You can develop and capitalize on relationships, as well as provide sort of additional goodies or remediation services for your members. Unfortunately, these cannot be charged as medical expense. So essentially, plans who went with this route had to rely either on external funding, or they had to charge against administrative funds. And this may be more difficult to sustain over a long term from the financial perspective. And let me point out briefly that every plan obviously is different. So there were several plans where they did essentially charge it to administrative funds, but they had the support of their leadership and commitment from their leadership to sustain this program. So that may actually be a viable option, but for some plans, this was a huge concern. So I will, given the time, I will stop here and open the floor for questions.
Thank you, Shirzad, for the great presentation. As Shirzad mentioned, the floor is open for questions. If you would like to ask them, you can do so in the chat feature in the webinar. And Shirzad, while we wait for some questions to come in, I have one thing that I'm curious about. So you mentioned at the end there about the two options available to health plans. Are these mutually exclusive? You mentioned the value of partnerships and that many plans are interested in partnerships. Can these two options be combined?
So that's a great question. We have heard, and then this is where every plan will have to make this determination on their own, given their specific situation. In some cases, there were partners that there were plans that partnered with outside organizations, and they were able to process their costs as medical expenditures, and yet the partners themselves were very efficient and effective in reaching out to their members. So some coalitions that are able to essentially have a billing code and provide effective home assessment will offer this opportunity. But in some cases we've heard from some plans who have partnered with, let's say, visiting nurses associations, and they had a very low engagement from their members.
Sure. Okay. Well, that's good information. Thank you for sharing that. And you had also mentioned it in the discussion. Do you think this information helps enlighten some of the areas for opportunity for plans? Maybe look at some of the best practices and what other plans have gone through already. Is this opening a doorway for future activities?
Well, certainly. I think the biggest lesson we've seen through all of our through the study was that you really need to consider it from the member's perspective. I think this all other issues are something that plans are already have a pretty good handle on, and this was probably the most surprising finding for us and for the plans, that the value of these home-based assessment may be obvious to us looking at, say, reduced healthcare utilization, reduced ER visits, and so on, but it's not necessarily something that's obvious to members. These are often for people who think that once they had an ER visit, well, that they took care of this problem, and they essentially it goes out of their mind, and they're no longer interested in this problem until they have another flare-up and they have to go to ER. So really engaging members is a critical piece to the success of this program.
Great. Well, we have a question in from the audience as well. Do you have any information on the approximate range of what health plans are paying for home-based assessments? And as a follow-up to that, how do you think this leads into return on investment? Have plans seen good results from that?
Well, we did not ask, and I think we usually have a blurb early on in terms of anything related to prices or pricing services. So we did not ask, for legal reasons, we did not ask this information, and we cannot ask, and we cannot divulge it either. So with regards to return on investment, there have been a number of plans who have calculated or attempted to calculate return on investment, and they did find promising results. So this is one of the reasons why EPA was making the case that this would actually be a program that would pay for itself in the long term. One thing to caution, though, and this was something that one of the plans shared during the roundtable, is that you cannot expect to see the results like the next year. You have to make a commitment of at least 3 or 4 years before you expect to see any positive outcomes and any positive results from this program. So you have to give it some time. But overall, those who have been able to essentially solve the issues with engaging their members, they have reported that they did see a positive ROI on this.
Hi, this is Tracy Mitchell from EPA, and I just want to make a plug for, again, on AsthmaCommunityNetwork.org, there is information about building the business case and about return on investment information, specifically, again, not specifically maybe for health plans, but there is information on the website about how programs can build their business case, whether it's a community program or a health plan, and be able to use those resources and materials to help with return on investment. It is a very tricky, sometimes difficult nut to crack with that information. But I like, Shirzad, that you said in some cases it's not that health plans aren't seeing the return on investment, but they have difficulty in gathering that information to be able to kind of demonstrate that. So I just like to offer Asthma Community Network up as a resource for programs out there.
Yeah, well, thank you, Tracy. And the other issue to keep in mind is that it's not just the return on investment. There's also the other metric that many plans used was improvements in quality of healthcare. So, and that is another metric to see that sort of essentially reduced ER visits, better medication adherence, and so on.
Okay, great. And one more question from the crowd, it seems like. Are there risk issues for home assessments via in-house community health workers? Is this a significant thing to be considered a con for using in-house community health workers?
We've only heard it from one of the plans mentioning that this might open up sort of a potential to potential legal liabilities. But other plans, like most of the plans who have these programs, who are up and running, we actually haven't heard anything to that regard. Part of it is also the fact that most plans actually contract out the actual assessment piece of it. So it may not be the health plans dealing with it, but rather their partners.
Great. And if there are any other questions, please submit them at this time. I'll give it just a minute. And while we wait, I would just want to say thank you, Shirzad and Tracy, for providing all that great insight for the audience. And I know I'm appreciative, and I hope everybody else is as well. This is a great learning session, and as mentioned earlier, a great opportunity to look into some of the opportunities that are born out of this information. And with that, it doesn't look like there are any new questions coming in, and we're right about at the end of the hour. So again, thank you very much, and thank you to our audience for attending today. We really appreciate it. And should you have any questions, feel free to send them over to myself or Shirzad, I believe our information is in the slides. If not, you can contact us via ahip.org/asthma or via AsthmaCommunityNetwork.org. This webinar will also be available to share on both of those resources. Please keep an eye out on AsthmaCommunityNetwork.org, as this will be the first place for it to land. Again, thank you very much, and we hope you have a great afternoon. Thank you, everyone.